हाँ चल रहा है. So good afternoon everyone and welcome to the post-lunch session of Hall C. I have been given a very difficult topic and I really don't know what to do with this. So I have tried my best to make it as relevant as possible. The topic is current understanding and nomenclature in abdominal wall anatomy. The nomenclature of course has changed a lot. Anatomy hasn't in past 300 years. But yes, I would like to speak a little on the concepts that are being utilized in complex abdominal wall hernia repair these days. This is me, and I'd like to invite my panelists now. Dr. Kumar Rai, Dr. Manish Mandal, Dr. Rajkumar Krishnasamy, Dr. Ramesh Agarwalla, and Dr. Sumanta Day is not here. I just spoke to him. So we have two of the panelists here, and I hope this panel discussion is worth everyone's time who's here. So let's start with the first scenario, which is a relatively recent change in hernia surgery, which is divarication. So let's start with Dr. Agarwalla. Do you think a divarication should be treated or it's only cosmetic?
So it all depends on what the patient has come for, whether it's isolated divarication, it's isolated divarication or it's combined with umbilical hernia, and if the patient is symptomatic. If we are seeing the patient for some other disease and divarication is there and patient does not want anything about it and does not have any symptoms, there is no need to treat the divarication. But if the patient is wanting for symptomatic, for cosmetic reasons, or has an associated hernia which is symptomatic, then when we are dealing with the hernia, we need to address the divarication. So it all depends on what he or she comes with and what are the associated factors with it.
Right, thank you, sir. So it all boils down to the tailored approach. And yeah, there is a screen here. So what if a divarication is associated with a hernia? Let's say it's a huge supraumbilical divarication and there is a small 1 centimeter umbilical hernia. You can actually get away with putting, let's say, a 12 by 12 mesh in an IPOM. Would you want to treat the entire divarication then?
So what happens is, if you're just going to put a 12 by 12 mesh, the whole thing is going to bulge out from there in the divarication. And I would like to treat it totally with the hernia and the divarication, do it fully. And I'm sure all the patients would also want that the divarication should also be treated. And I don't think we'll be able to do justice to the hernia without treating the divarication, because you won't have the base for putting the mesh. So it's going to be a thinned out abdominal wall to put a mesh there. So it's always proper to address the divarication with the hernia.
Right. Dr. Mandal, do you have any different opinions on this one?
No, strength has to be brought. And
right.
As Dr. Agarwalla has said, we have to treat both.
Right.
Leaving one aside will again come with recurrence and problem. So we have to treat both. Strength has to be brought back and then it shall be placed.
Right. So yeah, on the same lines, we have frequently seen these lateral recurrences. The basic principle of hernia repair states that when we are repairing a hernia and putting in a mesh, that mesh should be placed on a healthy tissue. Putting it on weak tissue doesn't really help as much. All meshes contract and the points of fixation get dragged out along with them. And that is where we see all these lateral hernias. Even with healthy tissue, we sometimes see it. So if there is a divarication, we should probably definitely not fix the mesh to this kind of a tissue. Next, Dr. Mandal, do we treat all divarication? For example, we are inside the abdomen and there was no mention of a divarication earlier. Suddenly the tissue is looking like this. Does this need to be treated?
It depends on patient to patient.
Yeah.
what type of patient we have, what is the strength involved, how much is the divarication, and yes, if the surgeon feels that it should be treated, then it should be treated. You know, risk and benefit has to be seen.
Yeah. And sometimes when we are inside the abdomen, even normal linea alba in a magnified view looks like a divaricated tissue. So it's important that divarication should always be a pre-operative diagnosis. Yes,
So
Dr.
another
Agarwalla.
thing is now, with so much litigations done, if you've not addressed the issue preoperatively and discussed with the patient, you cannot correct the divarication without the consent. And now there is a Supreme Court ruling that in between surgeries, you cannot come and ask them that, I've seen a divarication, can I do it? So unless until you feel that this is going to lead to any life-threatening complications otherwise, you cannot, legally you should not treat the divarication if you see that.
So the idea is a thorough pre-operative workup, see where the hernia is, whether it is associated with any weak tissues in the background, and take the call pre-operatively about what we are going to treat.
You need to have the consent.
Right.
So welcome, Kumar.
Welcome, Dr. Kumar Roy. And we are talking about divarication in hernias. We have spoken about whether all divarication need to be treated, whether divarication needs to be treated when it is associated with hernia. And now we are moving on to, we have established that when it is associated with hernia, it definitely needs to be treated when we are treating a hernia. So do we have a classification system for this? Because any treatment and treatment strategies will depend on a classification system. It is important for prognostication and tailoring of the approach. So, Dr. Mandal, do you think we have any classification system for?
Yes, we do have, and we have to go through it before we decide things.
Right. So, Reinpold's group proposed a classification for rectus diastasis from W1 to W3 on the same lines as EHS hernia classification. More than 5 centimeter is W3, and that's what they are saying is when the tissue actually becomes weak and it almost always needs to be treated. There are other factors that need to be taken into consideration when deciding to treat a diastasis. For example, is there any concomitant hernias? Is there a history of previous operation that might make the scar tissue weaker than it already was? What's the number of pregnancies that the woman has gone through, and what's the skin condition on top? All these factors need to be taken into consideration when speaking about the prognostication and treatment strategies of rectus diastasis. And what are the current recommendations for treatment of rectus diastasis with hernias? Are we treating it with mesh? Or are we doing a suture repair?
I think it is, if it is just your symptomatic umbilical hernia with a diastasis, then we do repair. And I do it preferably mesh. I mean, I prefer a rib stopper repair, mostly for those hernias with a mesh. So probably in soft, or polypropylene soft mesh.
So we have different kinds of repairs available for treatment of rectus diastasis as well. So Dr. Agarwalla, what would be a preferred method for a patient, or let's say, how will you select a patient for the kind of repair for a rectus diastasis? Would you do a Venetian blind? Would you do an open abdominoplasty? Would you do an endoscopic repair like scola or endoscopic rivestopper?
So personally, I would do a Venetian blind technique, but again, it depends on how much redundant skin is there, how much fatty tissue is there. If there is a very big panniculus, then I might go for abdominoplasty because that's not going to work. So it depends on a lot of factors. And for generally, it also depends on your experience. If you're not very comfortable with endoscopic suturing, you won't be able to do that. Then you have to go for an open method. But if you're comfortable with it, it's okay. If you want to do scola with the correction of divarification, that is also doable. Again, it depends on how amount of divarification is there. But you have to see the condition of the skin, you have to see the panniculus, and you have to see what is the extent of divarication.
Right. Dr. Roy.
I mean, do we have a case scenario here? So what did you do for this case.
So
One
these
opinion.
are two different patients. Yeah. Would you think that the
I
management
think
will be different for these two?
Vention blind laparoscopic
For
would be
both
good,
of these
good,
patients.
yeah, both these patients.
Yeah. Dr. I, do you differ in your opinion?
No, I think it's, this venation is the best method in this, as per the photos.
Okay. And Dr. I, what would you do for? These are two different patients. The patient on the left.
On the left I'm talking about. I mean, I don't know how symptomatic that patient would be. I mean, I'll just tell them to go and do exercise and come back.
Right. There is an associated hernia.
So what? If it's not a symptomatic hernia, I'm not going to operate on that.
Right.
If it's not symptomatic. And it looks like a small hernia, so I might just tell them to do exercise, strengthen abdominal muscles. The majority of these divertication patients have a very thin rectus muscle as well, and they're very thin midline. So, as you said, in pregnancies, majority are the female patients. So, pregnancy, I would ask them, if you're planning for another pregnancy shortly, then we don't go for the operation, which is another consideration.
Right. And you spoke about exercises. What kind of exercises, what kind of core exercises do you think these patients can do?
All the abdominal wall exercises like leg raising SLR with a binder on, and head raising, and both leg raising and head raising exercises, maybe cross training exercises to strengthen the muscles.
So recently
One important thing is that we have to avoid constipation in these patients.
Definitely, sir.
That is very important. How much you exercise you do, if patient is having constipation, then again, the more exercise is there, but constipation हुआ तो फिर again problem शुरू हो जाता है. You have to take care, especially if the patient is obese.
So there have been some recent recommendations on the kind of exercises that these rectus diastasis patients may benefit from, not that they do. All core exercises which involve an indrawing of the core, for example, planks or mountain climbers. These exercises are supposed to give some benefit to these patients. So moving on, we have already spent about 12 minutes on scenario 1. Scenario 2, we are going to speak about large hernias with thinned out and scarred skins. Dr. Rai, this question is for you. Do you think we should combine an abdominoplasty or paniculectomy with hernia repair in these patients?
As Ramesh mentioned earlier, if it's a big paniculus, then definitely we'll remove that.
Right.
But here there were multiple incisions, so before removing any skin, you need to be very sure about the vascular supply of their skin, how we are dealing with it.
Right. Dr. Mandal, what's your opinion on this?
The same. And most important is how much patient obese is. Because if the patient is obese and there is more fat, there is more chance of necrosis.
Right. Also involving an abdominoplasty to these patients, do you think that will actually increase the morbidity for these patients? We are adding a procedure. So do you think it should be avoided in certain patients?
It depends. It depends.
So for a patient like this, probably where we have already cut off the blood supply of a segment, especially the central segment, they may not do very well in the post-operative period. So this entire central area of skin needs to be removed. And there is also a recent recommendation by plastic surgeons, which says that now we know that as the hernia becomes bigger, the skin over the sac starts getting thinned out, and that skin slowly becomes parasitic and it is now supplied by the sac itself. So whenever we remove the sac, that skin mostly becomes non-viable. So it's better to remove that skin, and scars of course plays another role in decision making. If the vascular supply has already been compromised, we definitely do not want to keep that skin. Moving on, is there a role of liposuction or paniculectomy in these patients? Dr. Agarwalla.
So I have no idea about liposuction, but if there is a big paniculus, it's better to remove. It's better to remove. But if there is not much of a paniculus, then you don't deal with it. But if it's there, you should remove.
Yeah. So there is again a recent concept of a vascular steel where people say adipose tissue, although it was known to have a good vascularity, but it's actually supposed to be ischemic compared to normal tissue. So it causes a vascular steel phenomenon from the wound where the actual healing should occur. So it should be removed whenever possible, and even a liposuction does not hurt. That's what some plastic surgeons are saying these days. coming to the third scenario, subxiphoid hernias. So this is a patient with approximately W2 subxiphoid hernia and about 7 centimeter hernia in a scar of CABG. So what are the problems with subxiphoid hernia? That's the first thing I'd like to ask Dr. Agarwalla.
The problem is the anatomy. You have the rib cage there. So getting those planes, say if we had in central abdomen, we could have easily gone with a TAR procedure or rector rectus with a TAR procedure, which is not possible here. So you have to be very aware of the anatomy out here and what planes you're going to choose. So basically you're going to look at a plane between internal oblique and external oblique.
So why can't we do a retrorectus repair here?
You can, but getting the upper margins and the lateral margins is going to be a challenge.
Right. So
And you should be aware of the anatomy of the diaphragm at that area, so to put the mesh in the right place.
Right. So what are the different treatment options? Of course, in the past, we have done IPOM for a lot of these patients quite successfully. So Dr. Rai, I'd like to ask you, what are the different treatment options for these subxiphoid hernias?
I personally have done quite a few IPOM plus for these patients.
Right.
And at times, you have to make some release incision to get the midline closed.
How do you make those release incisions?
Big ones are difficult.
Right. How do you make those release incisions?
You can go inside and make cut on one side and make cut other side. Then somehow you pull it apart with a sac also. And because spreading of the mesh is easier in IPOM in these cases. Right. Open, they are actually difficult. You have to go in a very difficult terrain to do the repair. So average, moderate size, we'd go for that. But if it's a large defect, you cannot close it, then it's really difficult.
And what is the fixation strategy for this area? How do you fix your IPOM meshes?
I usually do with the transversal fixation on either side and absorbable tackers. And usually under surface, if you take down the falciform ligament and you just lay the mesh, it just stays nicely there. So you need a bigger mesh and just lay it down, it stays nicely.
Any role of sutures or glue there?
You can do. Gluing you can do. Suture also with the diaphragm, you can do few sutures.
Right. And other treatment option, open repairs or endoscopic repairs? Okay, the display is gone. Open or endoscopic repairs?
I haven't done any endoscopic. I don't do E-tape, so I can't tell.
No idea about it. Anybody having any idea about endoscopic repair?
Yeah, I think the benefit of doing a E-tape repair in this is because you are going in a retrorectus plane and you can go and you can take the fatty triangle down. It's a scarred area, so it's never going to be an easy operation. And if you do the transversus abdominis release in the upper part and you go below the TA muscle, you will see the decussating fibers, the plane between the TA muscle as well as the decussating fibers of the diaphragm. The idea of going into that plane is you can go at least 7-8 centimeters above the costal margin and you can lay a mesh. But of course, it requires a lot of experience because one of the big risks is that if you don't really know your anatomy well there and you make a hole in the diaphragm, patient may develop a diaphragmatic hernia later on. So definitely, I think that those who embark on a E-tape repair for this kind of hernia should have a good exposure to doing open TAR also in that region of the subxiphoid area. Because if you have seen the anatomy open, then only you can do it endoscopic.
Yeah. So Dr. Mandal, do you want to take us quickly through the anatomy of costal region and subxiphoid area in terms of muscular planes?
Nicely drawn, you can go ahead with it.
Okay. Yeah, so near costal margin, in the posterior rectus sheath, just when we start dividing the posterior rectus sheath, we find the TA muscles, which are present even medially in a fleshy form, and dividing that will lead us to the diaphragmatic contribution to PRS. We should keep in mind that just dividing the TA is not enough. We also have to divide the diaphragmatic contribution to PRS because otherwise we will enter just above diaphragm. will go in between TN and diaphragm, which Dr. Shah was just talking about, and will cause a diaphragmatic hernia. So that would be an incorrect dissection plane. The correct dissection plane is dividing even the diaphragmatic contribution to PRS and going into the plane between diaphragm and pre-transversalis space. And at this point of time, we should nicely be able to see the decussation of diaphragmatic fibers and TA at right angles to each other.
Just a point, we just had Dr. Garcia Urania speak yesterday on Madrid modification of this procedure, TAR procedure. And one of the things that the Madrid modification does is that he does not cut the TA, the posterior rectus sheath from the xiphisternum insertion. So just below, as it dips into the xiphisternum, he takes the falciform fat down and enters the plane posterior to the preperitoneal plane, just as above the falciform fat. So, he does not cut, and he said that he's done that now very successfully, and he does not really cut the PRS insertion into the xiphisternum. So just mentioning that there is a Madrid modification to the traditional procedure also.
Yeah, so that would be a medial to lateral approach rather than a lateral to medial approach. Yeah, yes, sir, please.
I am Dr. Abhimanyu. So, as we are talking about this extraperitoneal approach, TAM also comes in very beautifully in such cases, where we raise the PPRS flap. Yeah. So, as Dr. Sumit rightly pointed out, as we approach that triangle, then thereafter we just need to stay in the preperitoneal plane. So, that will avoid any sort of injury to the diaphragm. And since the upper limit is usually the xiphoid, so we can comfortably slide at least 5 centimeters, 6 centimeters cranial to that, and there the mesh absolutely rests comfortably. So TAM is another very beautiful approach which can be done, and everything remains intuitively under vision also.
Definitely, sir. And how easy it is to bring the peritoneum down in this area above the costal margin?
So when we are reducing the peritoneal sac, in cases of this subxiphoid hernias, so that sac also becomes very handy, because it allows us that extra purchase, and we just remain at the caudal edge of the defect, we remain absolutely close to the peritoneum, so that fibroareolar tissue actually leads us further at least 5 centimeters cranially. So we don't need to have that if someone is lacking in that intricate detail of the anatomy, as you showed the insertion of PRS and diaphragmatic musculature, even then you just slide in the preperitoneum plane.
Right, thank you, sir. So this is a small 1.5 minute video showing the extraperitoneal approach. So we are already in right retrorectus space, and we are dividing the PRS to get into pretransversalis space. This is around the time we also cross the midline, but since this is a subxiphoid hernia, it's not like a usual ETEP. We have already entered the peritoneum, and now we are dividing the posterior lamella of internal oblique. Remember, the layers that we will divide here will be posterior lamella of internal oblique, TA muscles. You'll see the fleshy fibers of transversus abdominis being divided now, and below that we'll divide the diaphragmatic contribution to PRS. As we develop the space superiorly, at some point of time we should be able to see this at right angles, the diaphragmatic fibers coming in. So right around this area you see TA muscles are coming in this way, and diaphragmatic contribution are coming at right angle to this. And that is when we realize that we are in the correct plane. But of course, if we don't see that, it's already too late, and we have entered above the diaphragm and caused a little trauma. Not sure if there will always be a hernia, but it can cause a hernia. Moving on to our next scenario, we have 5 more minutes, so we should be able to cover our next scenario. Subcostal hernias. Again, Dr. Agarwalla, what are the problems of subcostal hernias?
The problems are similar, what we've dealt in the previous scenario. So same, getting the space, getting the upper margins is going to be difficult.
Right. Dr. Rai, do you see any added problems with the subcostal hernia?
Yes, because all these rooftop or subcostal incisions is the problem is the upper part. I mean, the rib cage comes. And also problem is the lower part because you have a denervated muscle in the lower part. So that you have to keep in consideration. So it is all the lateral hernias like subcostals are very difficult ones. I mean, there are several techniques that are being advocated for that hernia. Even, I mean, old days we did a lot of even IPOM for those subcostal hernias. And they're usually multi-defects. You will see, all multiple defects are there. So IPOM has got some role in there.
Okay. And for open surgeries, what options do you have?
That's interesting. Open surgery, I mean, you have to go in between muscle layers.
Yeah. Most of these hernias will tend to be very big.
Very big. And so you keep as much sac as possible, and then you don't go in between internal and transverses. So you can create a plane between external oblique and internal oblique. And I've done quite a few like that, and then place the mesh intramuscular plane, and then repair the top bit.
Right. So in subcostal hernias, very interestingly, these days people say that it's easy to stay between internal and external oblique. And the way these muscles insert into ribs, you even get enough overlap superiorly if you stay in between internal and external oblique to place a mesh. Lower down, you can get into any plane because it's already denervated, but if you stay in the same plane, well and good. And this is what recent recommendations say. The lateral dissection is between internal and external oblique, and dissection is carried out laterally as much as possible. Medially, you have to get into retrorectus space to place a mesh adequately. Sometimes when the defect is too close to the midline, you may have to get into the opposite retrorectus space as well. And in the upper part, you will end up dividing 1 or 2 segmental nerves when you are in this plane, as you are dividing the posterior lamella of internal oblique as it contributes to the PRS. But lower down, there is no such danger. The muscle is already denervated, so you can get into this plane safely and you can do this repair.
Another problem is that, you know, they may be associated with semilunar line injury, because these are lateral incisions, and you know there already may be a semilunar line injury when you have when you are dealing with this. The second way that you burn your fingers is that when you take when you think you will do a midline incision for a lateral hernia to get into the TAR plane, right? So that is because we are all used to getting into the TAR plane by doing a midline laparotomy. So if you try to do a midline laparotomy and then you get into that plane, now you are sort of, you know, caught between trying to close the lateral defect. If you close the lateral defect, your anterior rectus sheath does not come in the midline. If you try to close the midline, your defect doesn't close. So I think, you know, it is important that, you know, you have to understand this thing, that even though you may have to get into that plane, giving a midline incision for a lateral hernia is not a good idea. You know, I have realized it after doing it, that how it's a very painful situation. I got into a very tough situation. So this is after realizing, so for a lateral hernias, you have to give a lateral incision. Whether you come from lateral to medial side is a different aspect, but you cannot do the conventional TAR from midline for a lateral hernia.
Right. Thank you, sir. So the last slide of all, I'd like to conclude before thanking my panelists. Anatomy has not changed in last couple of hundreds or thousands of years. It was always there, it was always the same. The way we started looking at it is different. Someone once kept looking at the anatomy of trilaminar muscles and realized that TA muscle is not actually ending at semilunar line, and it can be used to develop a plane between TA and transversalis fascia, and thus the concept of very large overlap of mesh started. So there are no newer concepts. However, our understanding keeps on getting different depending on how much we keep on looking at our available resources and our patients. So with that, I thank our panelists, Dr. Rai, Dr. Mandal, Dr. Agarwalla, and thank you, Dr. Sumisha and Dr. Abhimanyu, for their contribution. If there are any last words from our panelists.
Great. Thank you. Interesting panel discussion. Enjoyed it. Yeah. Thank you very much, Pallavi.
And one thing is that we have to individualize the patient in treatment of hernia. Every patient is a different patient.
Definitely. Thank you, Dr. Mandal.